I want to make short presentation about technique, methodology, and long-term results, dynamic correction scoliosis in adult. Usual clinical scenario for spinal surgeon who operated idiopathic scoliosis is the treatment of the patients with complete growth, moderate curvature who has radiological indications for surgery, but the disease is asymptomatic, no pain, and only deformity. Surgical correction in the patients with complete growth often raises concern about possibility of different complication, especially neurological problem. Patients who underwent surgical treatment of the idiopathic scoliosis at the younger age, as a rule, have fewer fixation levels, less blood loss, shorter surgery time, and fewer complication compared with adults who went through the natural history of scoliosis, its progression, and sought treatment later. Also, the X-ray correction data are similar, and improvement in the quality of the life after surgeries observed in both cohorts. On the slide, we can see evolution of the different instrumentation for correction idiopathic scoliosis. It's different distractors Harrington, Silke method, Cottrell-Dubosset system, and now it's gold standard posterior fusion with all screw fixation, sometimes anterior fusion with screws and interbody fusion. Our country, my country is quite big, and on the slide you can see cities where we do scoliosis treatment. It's most have localization in European part of the Russia. But in Vladivostok, there are some specialists who treat scoliosis. Problem with rigid stabilization in adult, it's PJK, DJK, resorption, bone resorption around the screws, revision surgery, arthrosis, broken of metal structures, and total limitation of mobility the spine, especially lateral bending, and complication level from adult scoliosis surgery very high, close to 50% of different complication and very high risk revision surgery. And main goal of improving spinal deformity surgery techniques should include reducing invasiveness, risk reduction, safety, early activation, reduced hospital stay time, and ensuring optimal long-term results. Now, according to dynamic correction, we have VBT technology, is correction due to growth modulation of the spine, partial restriction of vertebral growth from the convex side of the deformity. But the technology have big problem with the cord. About 50% of the patients have cord breakage. And now we have a new technology, ISC, anterior sclerosis correction from adult. Since the principle of remodeling is impossible in this situation, initially this is an approach to correction deformity in condition of complete growth of the spine, allowing them to maintain its flexibility. I began do dynamic correction from 2019. And now, first 300 patients was operated with Dynesis system. It's Zimmer company production. And we have long-term results from 311 patients. And one-stage dynamic correction of growing spine was performed 79 patients, and one-stage ventral dynamic correction in adult scoliosis 147, two-stage from left and right side 59, and combined using dynamic and rigid correction, usually rigid in thoracic spine and dynamic in lumbar spine. Observation period more than 1 year, 107 patients, and observation period more than 2 years, 46 patients. Average of time surgery near 2 hours. And when we're doing thoracotomy and close thoracophrenolumbotomy, near 2 hours. It's much shorter than traditional posterior fusion. Average time of hospital near 6-7 days, and we will see that very stable results after dynamic correction in thoracic and lumbar spine. After 2-3 years of correction, results very stable. This technique is possible use with endoscopic, thoracoscopic technique, and open technique. Advantages of anterior sclerosis correction is preservation of mobility of the spine, does not lead to fusion of vertebra, ensures continued growth of the spine, early recovery of activity. We give permission patients to do physical activity after 6 weeks after surgery. One-stage treatment retains the possibility of rigid fixation in the future if with dynamic correction will be any problem. And it's possible to use in elderly patients more than 60 years old. Usually we use mini thoracotomy, and we do thoracotomy through the 9 ribs and through the 5 ribs for up part of the thoracic spine and low part thoracic spine. We always make coagulation segmental vessels, and we do nucleotomy for mobilization deformity, disc release, all levels where we do correction and fixation. We should do preservations of end plates for prophylaxis of fusion. And sometimes we do resection of the rib in thoracic region for increased mobility. And we should take care about sympathetic chain for prophylaxis problem with damaged sympathetic chain. Surgical technique is more aggressive compared with VBT technique. We installation 2 screws into vertebral body. The tension of the second cord is the same as at the first. We always use only 2 cords. We can do the rotation of the sclerotic deformity with special instrumentation, and contraction body to each other after nucleotomy gives spontaneous rotation. Now you can see 2 patients 3 years after dynamic and rigid correction. From the right side is dynamic correction, left side rigid correction. Same levels of the fixation, and you can see that 16 years old girl have very good mobility, and patient to the left has big restriction, especially in lateral bending. Next stage, 50 plus ladies to the left side. She was operated Professor Ptashnikov in St. Petersburg, 2 revision surgery due to, and from the right side is doctor neurologist from Vladivostok, have done her anterior sclerosis correction, and now 3 years after surgery, she's skiing, can bending, and feels very good after surgery. On X-rays after surgery, after 3 and 4 years, does not lead to fusion. It's no fusion technology, and on the functional X-rays we can see movement in segments who underwent fixation. It's possible, of course, using like VBT technique. It ensures continuous growth of the spine. And patient after the surgery can back to the sport and do different exercises. We can do combination with rigid system. It is possible. Patients with rigid 79-degree thoracic and 64 in lumbar spine. We have done rigid correction in thoracic and dynamic in lumbar spine with good cosmesis functional results. 32 years old ladies, 5 years after anterior sclerosis correction from 61 degree to 19 degree. And good rotation, good functional, she doing yoga and not any problem with pain or loose correction. And I have a small group, 60 plus patients with lumbar sclerosis. We always do for this patient classical posterior fusion. And as I said, the level of complication in group elderly patients very high. Dynamic correction here is 2 years after surgery, shown good flexibility of the spine, no pain, and good healthy condition. And maybe in last century was big discussion what's better, for treatment of arthrosis of the hip, arthrodesis and endoprothesis. In my institute, my teacher said me that it was very big discussion in 50s and 70s years last century, and now all world doing total endoprothesis. And first endoprothesis was created in USSR, Professor Sivash, and in 47 countries this patent was bought, and in 60s and 70s this type of endoprothesis was had very big spread in the world. And now we have discussion between doctors who likes fusion and who try to do dynamic correction of the scoliosis. And I support, of course, dynamic correction because we can really see early activation, physical therapy complex, special exercises for spinal mobility. These patients doing yoga and return to sport after 4 or 6 weeks. And the more active the patient's behaviors, the better system works. For example, professional girl with 5 years after dynamic correction, it's the first cohort, and she's doing all exercises. And 3 years after surgery, champion of the Moscow region in powerlifting, in the weight up to 33 kilograms, and she can doing different exercises without any problem and no loose correction. And prospects for using of the method, scoliosis from 30 to 70 degree, hip or normal kyphosis. In some cases it's effective for deformity, especially thoracolumbar, of 80, 90 degree. Most of effective for thoracolumbar deformities, Lenke 5 classification. It works well with Lenke 1, Lenke 2, and sometimes in Lenke 6. And more optimal patients for surgery from 18 to 40 years old. Of course, we have complications after surgery. It's the main problem with thoracic. It's hemothorax, pneumothorax, neuropathy syndrome, sometimes malposition of the screw. For prophylaxis of complications, should training required, cadaver courses, and surgeon-to-surgeon visit to increase knowledge about this new method of correction. I performed revision surgery from patients with lumbar spine correction with neuropathy syndrome. Removed one screw because head of the screw make compression of the nerve root. And you can see malposition of the screw, what's needed to revision surgery too. In all cases, we should do neuromonitoring, especially in lumbar spine. In conclusion, I can say that dynamic correction in adult, a new direction in spinal deformities, fourth generation of instrumentation, a low-level complication, high efficiency of correction, rapid recovery, and now we have our local Russian products, Spine Flexis system for correction this deformity, and it's possible distribute on different market. Thank you very much. It's my patient after dynamic correction, lumbar and thoracic spine. It's special exercise for you. Thank you. If you have any question.
Yes, Professor, amazing presentation. I want to know, basically scoliosis surgery is because of muscle imbalance. That muscle imbalance is not going to get cured, it is there permanent for the rest of the life. So your entire construct is dependent on the, the cable which you have passed over the screw heads. Now this cable must have gone extensive biomechanical analysis?
Yes, of course. Now we tested patients after 2-3 years after dynamic correction, and condition of the muscles, balance and power of the muscles are much better compared with rigid fixation. And the main idea, dynamic correction, do prophylaxis progression of scoliosis, because we all know that natural history of scoliosis correction, especially in lumbar spine, step by step deformity increase, and patient come to us when rigid deformity with sagittal frontal imbalance, and we should do very high risk surgery, a lot of screws, fusion, and patients should pass through the different complication. But the dynamic we can do as a prophylaxis of scoliosis. Deformity near 30, 40, 50 degree, it's very good, very fast surgery and very good recovery. And muscle conditions is much better.
How long you think the cable will last? What is the life of that cable?
You mean follow-up?
What are there any studies that this cable will last for another 30 years or 40 years?
It's possible do in different age. We have done a lot of surgeries in 20 plus patients. From 20 to 30, it's best results because physical condition of the patients very good. 30 plus, it's good results too, very stable. 40 plus, it's a little worse because deformity more rigid and pain level not regression very quickly. But after maybe 2 months after surgery, recovery is very good. And 50 and 60 plus patients, it's possible to do this technology too, but I have very small cohort these patients and try to do the right selection. Patient with not very severe deformity, with more or less good balance. And when I've done maybe 7 patients 60 plus with deformity near 40 from 50 degree, results really good. No bone resorption around the screws and pain releases quite good too. But we should, of course, do it we don't go very quickly in this direction. We should step by step, I think. So.
Thank you.
Yeah. Thank you very much, sir. Very nice. So now we